Hello everyone, I'm Rafael Madero. I'm one of the chief residents at Mount Sinai Morningside West, and today I'm going to give you a brief overview on malignant spinal cord compression as part of our hem-onc emergencies curriculum. So we're going to start by the definition. So this is a compressive indentation, displacement, or encasement of the thecal sac that surrounds the spinal cord or cauda equina. And of course, we're talking about specifically spinal compression caused by cancer. What is the emergency? Why is it important? Basically, it is a condition that requires early detection and treatment to relieve pain and preserve function. So by preserving function, we mean that one of the prognostic indicators of neurological function after spinal cord compression caused by malignancy is the neurological function um, at the time it is detected. So basically, the earlier you detect it and treat it, then the better prognostic outcome the patient will have. And it is also a potential initial manifestation of malignancy as well. So something to keep in your differential. Talking a little bit about the epidemiology, it is most commonly found in patients with breast, prostate, and lung cancers. It is less commonly seen in non-Hodgkin lymphoma, renal cell carcinoma, and myeloma, as well as with other tumors as well. Some of the locations are, well, it's most frequently found in the thoracic area, followed by lumbosacral, and then by cervical. And an important thing to keep in mind is that a decent amount of these patients, probably about a third of them, present with lesions in multiple regions of the spinal cord. Some of the symptoms that the patient can present with, the most frequent one, of course, is back pain. Some of the typical findings or the most characteristic findings of the back pain caused by spinal cord compression, it's that it's worse when it's supine or with Valsalva maneuvers, and it can awaken patients at night. Another interesting finding is that you can have referred pain, meaning you can have a cervical lesion with subscapular pain, you can have a thoracic lesion with lumbosacral or hip pain, and you can have a lumbosacral lesion with thoracic pain. And in terms of neurological manifestation, you can have motor weakness, sensory impairment, autonomic dysfunction, talking about bowel and bladder, and lower motor neuron findings are usually asymmetric, while upper motor neuron findings are usually symmetric. Of course, you can have either presentation at both lower and upper motor neuron. Talking about the physical exam, they can present with tenderness to palpation. They present with hyperreflexia, though reflexes can later become absent. They also present with spasticity, loss of sensation, like we mentioned, position, temperature, pinprick, and vibratory sensation. And they can present with Babinski signs and decreased sphincter tone. These are usually late signs. In terms of the workup, cancer patients with back pain and normal neurological exam should still have imaging done within 48 to 72 hours. Once they start developing neurological symptoms, the condition worsens significantly faster than upon initial presentation. And, you know, if the patient does have neurological manifestation, um, then you require emergent evaluation and treatment. That's part of why it's included in our hem-onc emergencies curriculum for the reasons that we mentioned before. And in terms of imaging, whole spine MRI with contrast is the gold standard. Now, if MRI is contraindicated, then you can do CT myelography. Again, whole spine, because you can have not only multiple areas of the spine affected, but also because it can present with referred pain as well. So it's not always easy to define where the lesion is clinically. And I put this table together to kind of summarize and tie everything together regarding management. So I went over it by problem. First you have the compression that, of course, you give steroids initially. As we all know, it decreases inflammation, and improves neurological function. Just you have to be aware of steroid side effects. In terms of dosing, dexamethasone 10 milligrams IV times 1 can be given, and then decrease the dose to 4 milligrams Q6. The dosing is a little bit um, poorly defined, just because there is no definite consensus in what dose to use. This is a dose that has been found to be as helpful as higher doses and with fewer side effects, such as steroid-induced gastric ulcers. However, if your patient has worse neurological presentation, that's something that can be debated. Increasing the steroid dose as well. And you also have you can give the first dose of steroids if you suspect it strongly, this condition of spinal cord compression, just with the caveat that you have to be worried about, or if you're worried about a lymphoma that has not yet been diagnosed, because the lymphomas are very responsive to steroids, and you could end up having no tissue to biopsy. And then you also have radiotherapy. Lymphoma, myeloma, seminomas are highly responsive to radiotherapy, and you can use that as a significant part of the treatment. Surgery, you consider it if vertebral instability, neurosymptoms, and it depends on, as we saw, solid tumors are some of the most frequent causes of spinal cord compression. So it is a very important part of therapy. It also depends on the prognosis. Usually we talk about um, uh, life expectancy above 3 months. It's still reasonable because, in conjunction with radiotherapy, it has been shown to improve the quality of life of these patients, preserve ambulation, preserve bladder function for longer, and even a modest increase in survival as well, or prolongation of survival time. In terms of pain control, besides steroids, radiotherapy, surgery, you have Tylenol, NSAID, bisphosphonates, TCAs, gabapentin, pregabalin, and opiates. And in terms of mobility, don't forget to involve physical therapy and occupational therapy. Early ambulation diminishes risks of immobility. In terms of the psychosocial support, well, spinal cord compression carries a very grim prognosis. Usually, if they present like this, you're talking about a life expectancy of about 6 months. And palliative care can help you guide treatment goals even before you decide to withdraw care. And of course, talking about psychiatry, we're not necessarily talking about an emergent evaluation in the hospital, but we know cancer patients are also affected by depression. Of course, it is a very acute stressor, so screen for it and refer as needed. In terms of bowel regimen, depending on incontinence and or constipation, you should treat for that as well. In terms of bladder control measures, of course, straight cath for retention. Patients can, frequently urinate as well for incontinence, and just to keep an eye on that. And just some take-home points: work up all cancer patients with new back pain. Early intervention is crucial. Use a comprehensive approach, like I mentioned on the table, and it is the sign of poor prognosis. Address life expectancy and patient's goals. These are just a few of the references that I used to put together this presentation. I hope that it is very useful for you, and feel free to reach out to me if you have any questions.